Hello, Maryville University colleagues and distinguished faculty members. I'm honored to have this opportunity and excited to be here. My name is Jennifer Kirlangitis, a Doctor of Nursing Practice candidate, and I'm eager to present my DNP scholarly project titled Supporting Adherence to the Severe Sepsis and Septic Shock Early Management Bundle. First, I would like to thank my chairperson, Dr. Jennifer Taylor, who was instrumental in guiding me through the scholarly project process. In addition, I would like to thank Sandra Letourneau, Mel Hollis, and Glenda Johnson, my community members at the project site, who assisted me and supported this project. Sepsis is a leading cause of morbidity and mortality worldwide and one of the primary causes of death among hospitalized patients. Sepsis can lead to life-threatening organ dysfunction caused by a dysregulated host response to infection. In the United States, sepsis is responsible for an estimated 1.7 million cases annually, causing 265,000 deaths each year. Here is a critical point. The emergency department accounts for nearly 80% of sepsis cases. The majority of acute care settings utilize guidelines to manage septic patients based on the Severe Sepsis and Septic Shock Performance Measure Bundle, also known as the SEP1. It is a core measure mandated by the Centers for Medicare and Medicaid Services. The SEP1 core measure provides the framework for improvement in sepsis care through interventions based on best evidence. A sepsis protocol is imperative in the care of patients where providers employ the recommended best practice strategies, thereby improving their quality of care, preserving life, and decreasing the associated morbidities. Adherence to these interventions increases the chance of survival and reduces the severity of the devastating effects of sepsis. Estimates indicate that over 970,000 people are admitted to the hospital with sepsis annually in the United States. In-hospital death rates from sepsis are as high as 80%, and sepsis is the second leading cause of death among patients with shock. Globally, sepsis accounts for 5 million deaths annually. These statistics underscore the significance of utilizing strategies to improve patient outcomes through interventions that demonstrate best practice and effectiveness in decreasing mortality. Improving morbidity and mortality rates is the primary objective of the SEP1 core measure, and studies show a reduction in mortality through the use of evidence-based clinical guidelines. In addition, the evidence also shows that educational interventions, electronic alert recognition systems, and rapid response teams improve patient outcomes. So when adherence to the core measure is evaluated, we're asking, is a change needed, or are our efforts currently in place meeting quality standards of care? Without such evidence, there is a potential compromise in patient care and outcomes. The SEP1 core measure is highly significant to nursing, as nurses deliver the majority of sepsis care the patient receives. Providing patient-centered, evidence-based care is core to the nursing profession. Nurses are committed to ensuring that clinical processes and interventions produce the intended effects and outcomes. In addition, nurses also feel a sense of duty and professional responsibility to know what supportive evidence indicates effectiveness of clinical processes. Therefore, the significance of evaluating adherence for nursing practice is that it offers confidence that the organization supports care processes that reflect the highest standard and allows nurses to engage in improvement efforts. Advanced practice nurses play a significant role in sepsis management in the ED setting, where they depend on utilizing effective tools and evidence-based strategies to guide care. The nurse practitioner is uniquely qualified to impact sepsis care by ensuring compliance with the SEP1 core measure and the provision of proper education that corresponds to best practice. One of the core essentials of doctoral education for the nurse practitioner is striving to improve outcomes by promoting and advocating for change. So the overall objective of this scholarly project was to analyze adherence to the SEP1 core measure in the ED setting at the project site with the purpose of determining if an educational intervention was effective in improving adherence rates. This inquiry aimed to investigate current adherence and determine if the project's educational intervention improved compliance and to what degree, or how effective was it? Another aim of the project was to determine the educational intervention's effectiveness in reducing sepsis morbidity, specifically hospital length of stay, ICU length of stay, and the number of days a patient required mechanical ventilation. And then lastly, a final objective was to disseminate the evidence to the project site to offer guidance on the facilitation of change and delivery of quality sepsis care. Across the literature, there were 5 common themes pertaining to sepsis management. One of the most prevalent is that the key to increasing survival correlates with early identification. A second theme is that rapid implementation of the SEP1 core measure reduces pathogen burden while modifying the host response, potentially decreasing the incidence of subsequent organ dysfunction. Tying these 2 themes together then, the evidence is consistent that using the concept of treatment implementation at the earliest stages shows a significant reduction in morbidity and mortality. A third recurring theme is that standardized protocols reduce morbidity and mortality by decreasing the progression of sepsis to irreversible organ damage or septic shock. A fourth theme is that accurate measurement of the impact of the SEP1 core measure is highly dependent on adherence to the protocol. Studies are consistent that compliance with the guidelines ensures that the identification of septic patients is rapid and accurate, and the initiation of the intervention is within the SEP1 core measure timeframe. And finally, a last theme is that educational interventions impact adherence. Quality improvement programs initiated to improve sepsis management are linked to a significant increase in adherence to the SEP1 core measure and a subsequent decrease in mortality. The diffusion of innovation theory by Everett Rogers served as the conceptual framework for this project. Rogers acknowledged when he described the diffusion of innovations theory that getting new ideas adopted, even when the advantages are apparent, is often met with opposition, and we can all relate to this either on a personal or work environment level. Rogers identified 5 stages of the innovation decision process: awareness, interest, evaluation, trial, and eventually adoption. Some of the basic concepts of the project included that early identification is key to survival, protocols are fundamental in this identification, and adherence is integral to success. By moving through the theory's 5 stages of diffusion of innovation, the project enhanced current knowledge regarding sepsis management and then persuaded decision makers to act on the results. There was a need for compliance improvement in the ED at the project site. As mentioned, SEP1 performance scores were deficient, compromising patient care. It was essential to evaluate if an educational intervention would improve compliance and to what extent. A non-blinded quantitative exploratory methodology was used to investigate the research inquiry through a retrospective chart review of the electronic health records, or EHRs, of those treated in the ED with a diagnosis of sepsis, severe sepsis, or septic shock. This project focused on the ED setting. Recall that I mentioned before, it is this environment that often encounters the septic patient and where sepsis is commonly diagnosed, but more importantly, affecting a change in adherence where the biggest impacts on outcomes are felt was central to the project's purpose. The EHRs extracted for this project included patients diagnosed with sepsis, severe sepsis, or septic shock from any infectious source who were age 18 and older. The project included all genders and ethnicities. Confirmation of ED presentation during the specified intervention period was another criteria, as well as confirmation of the patient's diagnosis in the ED. In terms of the educational intervention, it focused on early identification of sepsis and septic shock, rapid implementation of the 11 core measure elements, and accurate documentation per CMS guidelines. The education was presented through a 12-minute PowerPoint presentation and delivered in an online format through HealthStream, the organization's educational platform, during annual mandatory employee education. The ED staff had access to the educational module for a 1-month period, which allowed adequate participation time. A combination of descriptive and inferential statistics were utilized in the project. For example, descriptive statistics characterized 3 demographic data points related to the participants, including gender, age range, and ethnicity. The statistical method used to analyze these data points was the mean or average for each. Let's look now at the inferential statistics collected. There were 2 separate analyses, one related to adherence rates and the other related to sepsis morbidity. Now, from an adherence rate perspective, this is critical because for hospitals to remain compliant with the core measure, each of the 11 interventions must be delivered in the specified time frame because CMS does not acknowledge partial completion. In other words, it's all or none. The data collection instrument utilized corresponded with the elements of the SEP1 core measure. Data were collected on each component of the sepsis protocol before and after implementing the educational intervention to assess adherence. Percentages were utilized to make a comparison, then a one-tailed non-parametric z-test was utilized to evaluate the significance of these proportional differences between the 2 independent groups. The second analysis evaluated sepsis morbidity. Key factors implicated in poor outcomes include hospital and ICU length of stay and the number of days on mechanical ventilation. A 2-tailed independent samples t-test was utilized to compare the means of the 2 intervention periods to determine if there was statistical evidence of significant group differences. I would like to share a quick illustration of how the SEP1 elements are broken down for additional clarity, particularly in terms of time frame of administration. As seen here, timing is a critical component of the SEP1 core measure, underscoring how adherence is often problematic in a busy ED setting. Now, looking at the demographic details, the results show in Table 1 that more participants were male compared to female in both intervention periods. Table 2 shows the age ranges of the participants, and in both intervention periods, the data showed the majority were those age 65 and older, with the fewest participants being those 18 to 40. Then, as seen in Table 3, in terms of the ethnicity of the participants, the majority were non-Hispanic white, and the minority were Hispanic in both intervention periods. Next are the results of the difference in SEP1 element completion between the 2 periods to evaluate the effectiveness of the educational intervention on adherence. As illustrated in Table 1, there was greater adherence in the post-intervention compared to the pre-intervention period. There were 2 exceptions, one being adherence to vasopressor administration within 6 hours of sepsis presentation, which showed 100% compliance in both periods, and then there was a slight decrease in compliance with collecting a lactate level within 60 minutes of presentation in the post-intervention period. This data was collected using nominal values and evaluated utilizing the average administration of each component. Now, Table 2 shows the results of the z-test, which was utilized to determine the difference of the 2 independent group proportions. The difference from pre-intervention to post-intervention was 15.4%, demonstrating an increase in adherence to the SEP1 protocol after implementation of the educational intervention. The significance of these proportional differences is shown in Table 3, where the results reveal a true change in ratio from the pre-intervention to the post-intervention period, indicating statistical significance. The last outcome evaluated in this project was determining the impact of the educational intervention on the sepsis morbidity factors. The table on this slide shows the result of this analysis, demonstrating there was no significant difference between the 2 intervention periods and therefore no statistical evidence of group differences in the 3 sepsis morbidity factors. So what does this all mean? The primary finding of this project demonstrated improved adherence to the SEP1 core measure after implementing the educational intervention. The results of multiple studies correspond to this project's findings, where providing knowledge about sepsis and septic shock, sepsis management consistent with the SEP1 core measure, and accurate documentation of time-sensitive interventions according to CMS guidelines improved compliance. Most importantly, the project's findings of increased compliance concludes that the educational intervention achieved the intended goal of improving care delivery to septic patients at the project site through adherence to the SEP1 core measure. Secondarily, increased compliance improved SEP1 core measure performance, where previous scores indicated underachievement at the project site. An enhanced performance score shows progress in sepsis care, which is reported to CMS and in the public domain. These accomplishments are central to the facility's accreditation, as it demonstrates an upholding of the highest standards of sepsis care and their commitment to improving patient outcomes. Another finding in this project revealed no evidence to support that the educational intervention affected the 3 sepsis morbidity factors. Because the ultimate goal of sepsis education is to improve patient outcomes and reduce mortality through adherence to the core measure, this was a critical finding in this project. Similar studies show comparable results in hospital and ICU length of stay with no statistically significant findings after implementing an educational intervention. However, in contrast, other studies do demonstrate reduced hospital length of stay after implementing an educational intervention where length of stay was decreased in the intervention group. What I can conclude about these studies is that the larger sample size utilized in some studies and their involvement at multiple sites, in contrast to the small sample size used in this project at one location, potentially provides context for the differences noted. It is also possible that an unforeseen event during the post-intervention period impacted the project results, making it challenging to draw inferences about the intervention's effectiveness on sepsis morbidity. Many people who presented with COVID-19 also had a diagnosis of sepsis or septic shock, which changed the dynamics of patient illness severity. Sepsis severity data was not collected in this project, therefore inferences about the intervention's effectiveness on sepsis morbidity factors are unclear. There were both strengths and limitations in this project. Strengths of the project included the retrospective chart review design, ample time frame for implementation and data collection, the educational intervention's online delivery format, and then finally the rigorous data collection methods and analytic process measures utilized. There were also limitations in the project. First, there were newly employed staff members hired to accommodate the influx of COVID-19 patients. Their exposure to the educational intervention was unclear, which potentially impacted the interpretation of the results. So the increase in compliance noted may not be entirely attributable to the educational intervention. Also, the lack of data collection related to the severity of sepsis illness potentially impacted the results. This might have limited the observance of more explicit inferences about the intervention's effectiveness on adherence. Collecting this data was not initially relevant to the research inquiry. And then finally, the project's small sample size, which can impact the representativeness of the population, thereby an estimation of the population value. One impactful barrier in this project involved the ramifications of conducting a project during a health crisis that initially delayed the ability to be on site for data collection and implementation of the educational intervention. These restrictions and delays necessitated changing the intervention's delivery method from in-person to an online format embedded within HealthStream. Another less impactful barrier involved data retrieval, where the EHRs was not a straightforward. Reviewing the EHRs was not a straightforward process. Locating data on the administration of each of the 11 SEP1 elements required many search hours because there was information documentation in erroneous areas of the health record. This barrier made it necessary to adjust the original time plan for data retrieval. The facilitators in this project involved organizational and leadership structures. The organization was supportive and very eager to improve sepsis management, and their performance scores on the SEP1 core measure were deficient. Quality sepsis care requires leaders knowledgeable about management, the SEP1 core measure, CMS guidelines, and time-sensitive documentation. these essential requisites highlight the importance of the sepsis educator's role, made possible by the organization and their efforts to deliver quality sepsis care. A second relevant facilitator relates to the organization's health informatics infrastructure, including the electronic health record and the health stream technologies. The EHR was integral in facilitating the data collection process. Also, the ability to offer the educational intervention through HealthStream provided a convenient, user-friendly online format which facilitated the uptake of knowledge and the project's successful approach in applying evidence to practice. The evidence clearly acknowledges that standardization of care processes creates consistency and reduces gaps in care. This project identified the gaps in sepsis care where there were deficiencies in adherence to several of the SEP1 elements. The project also highlighted the inconsistency in sepsis management where there were delays in administering time-dependent components. In addition, the project revealed opportunities for refinement of care processes, creating a pathway for clinical practice improvement. Knowledge acquisition and the value of invoking a positive change in behaviors and processes is indispensable in terms of improving clinical practice, as illustrated in this project. This project contributes to vital future research on utilizing educational interventions as a successful strategy for improving adherence to the SEP1 core measure. This positive impact denotes significant progress toward informing sepsis quality improvement programs in healthcare systems. In addition, the project highlights the need for future research on the associations between adherence and a reduction in sepsis morbidity. The non-significant findings in sepsis morbidity reduction, despite an increase in adherence, emphasized the importance of evaluating other factors implicated in the progression of sepsis and how restructuring education based on those factors might have a role. This project substantiates the need for educational programs that improve sepsis outcomes, urging healthcare leaders and policymakers to engage in discourse and support research that advances sepsis education. The first step in creating health policy is defining the scope of the problem, and the project successfully contributed to illuminating the deficiency with adherence, which consistently plagues ED settings. Another way research influences policy is by illustrating the benefits of interventions or solutions to the problem. The project results showed the significance of education on adherence to the SEP1 core measure, which is key to developing a health policy that supports sepsis education. Informing health policy involves convincing policymakers that a proposed intervention worked as intended, and this project provided a clear context for implementation. In summary, the results of this in-depth analysis supports adherence to the SEP1 core measure in the ED setting through an educational intervention to improve the quality and safety in sepsis care delivery. Furthermore, finding no significant evidence that the educational intervention and improved adherence reduce sepsis morbidity highlights the need for future research. The recommendations are for future research to focus on determining which intervention strategies are more successful at improving compliance rates, and then examine the associations between educational interventions and sepsis outcomes. I thank you for the opportunity to present my DNP scholarly project.